Dr. Nishant.
Sir.
So, Anand, can you change the name also? Some Lalit Yadav or something is coming.
Okay.
Anand?
That is me. That is me, sir. I told you now. I'm using someone else's device. I'm outside, out of Patna, right?
Okay.
So you can
Go
take
to
Lalit
Dr.
as me.
Tiwari sir. Dr.
Sir,
Tiwari sir.
pranam.
Thank you.
Tiwari sir, pranam. Pranam, sir.
Pranam. Thank you, Dr. Ajay. It is you people who have made this program very successful. I must thank and congratulate you, all master teachers of this class. Today you have caught Nishant Tripathi. Actually, what should be like that? Nishant Tripathi with us to take this class.
Sir.
I will request Nishant to start, please.
So before Dr. Nishant starts, I will briefly
Introduce.
give a mild sketch of whatever he has been. He's a stalwart in cardiology in not only in our part but at the national level. And Nishant has been working in IJMS, and he was in IJMS, and then he switched over to Paras. He was working with us in Paras. He became director interventional cardiology there, and then he has nth number of contributions in the field of cardiology. And I thought to give him a very simple topic, like how to learn clinical cardiology from uh, a master teacher like him. So Nishant, although he looks very young, uh, he's so dynamic. He has got his own hospital, and now this hospital in Patna is one of the landmarks in the field of cardiology. He with Dr. Ashok, who is another fine colleague with us, and others, they have started a new project which is running very well in Patna, known as SDNA. Is it correct?
HDN, yes, sir.
SDNA in Patna, uh, on Belly Road itself. And he has been a contributor of a lot of cardiology advances in our city or Patna. So, and he is a DM from Sanjay Gandhi Institute, Lucknow, and he has been doing fantastic, and he has been a contributor of all our programs. Whatever we do in Patna, always invite Nishant, and he has never said no to us. So over to Nishant. Thank you.
Thank you very much, sir. Ajay sir, thank you very much for your kind words. It's always the support of seniors like you, mentors like Tiwari sir, and all the people who supported me in my journey. And that's the most important thing. I believe the cardiology community in Patna in particular and Bihar in general is very close knitted, I will say. And everybody is supporting in this way. So I agreed to this program. As Ajay sir told, I was also in transit. So uh, as I told, it's a wonderful thing. Agreed because I also wanted to refresh up things away from academic medicine. I must admit that I've been away from academic medicine for so long. So it's a good opportunity for me also to learn and refresh things. And I hope the participants get some benefit from this talk. I'll just share if my screen is visible or not. I'm not sure. Can we?
Share your slides, please. Huh?
Yes. So I will just do it. Just
Yes.
bear with me.
Yeah, take your time. Take your time, please. No problems.
Anand, help कर दो.
Yeah, we got it. Got your slide. Can you make it a full screen?
ओके ओके, नो नो नो, आई गॉट इट। इसको बड़ा कर ले अब,
हाँ, full
कर दें।
screen कर. हाँ.
सर, am I audible now?
Yes, you are
Screen
audible.
screen is visible, right?
Yes, screen is visible. It has to be made
Okay.
full screen, that's all.
Yeah, yeah. Now it's okay.
Yeah, but still it's not full screen.
अच्छा, just a second. Screen out. Hello, sir. Now I
Yeah, it's all
guess
right.
everything
Go
is
ahead,
set up
go ahead.
now.
No problem.
Okay, okay,
Go.
okay. Sorry for some glitches. As
No,
I
no, no,
told,
no issue.
I
No
was out.
issue.
So,
It's our home.
as I said, it's good that we are refreshing things up. So, examination of cardiovascular system for uh, be it an MBBS student, MD, or DM, it's the basic. And when I say basic, because technological advancement has been so much in cardiology, especially that people are forgetting the art of examination of cardiac system. And as I said, as I've been away from academic medicine for last few years, but I still believe that clinical medicine cannot be taken away from any technological advancements, AI, no matter how much it comes. So my suggestion to all the younger colleagues, the younger students, please never lose focus of clinical examination in medicine, because that's the only thing that will give you an edge and it may make you different, no matter how much technological advancements come. So when you are doing a cardiovascular examination, remember there are two parts, cardiac and vascular. Many a times students feel that it's only heart. But when you are doing a cardiovascular examination, it is cardiac, that means heart. Vascular means the arteries, veins connected to the heart, and also the extra cardiac features that you do in a general examination. There are so many information that you can get from your general examination. At this point, I will also like to emphasize on the point of a good history taking. I'm sure that teachers like Tiwari sir, Ajay sir have been focusing on this part in all other classes, that a proper history taking is the core of internal medicine. If you don't take a good history, then the examination becomes a bit tricky. I will say you won't be able to correlate the things and you won't be able to reach at a proper diagnosis. So I suppose that you have taken a good history, and then only we should be moving forward. So now what? Sorry. So before going up to the examination part, let's do a quick recap of some surface landmarks. When we examine uh, cardiology, we are focused on the thorax. So there are some surface landmarks that you must remember: the midline, the anterior midline, mid-clavicular lines, parasternal lines, and you focus on the axilla, then there is an anterior axillary line, posterior axillary line, and a mid axillary line. These landmarks have to be remembered because of the relation to underlying cardiac structures. Then you also have to remember the intercostal spaces and their relation to cardiac anatomy. Most important is the second intercostal space, which is called sternal angle. Then the second intercostal space, costochondral junction, because they are related to important blood vessels, aortic valve, pulmonary valve. Then the fifth intercostal space you have to remember because the apex of the heart lies somewhere medial to the midclavicular line. And similarly, in relation to these surface landmarks, you have to compile your clinical findings. This is also border of the heart I'm highlighting. So what I was telling you, because these surface landmarks relate to the underlying cardiac structures, you can see they have been marked there, and all those important structures like right atrium, right heart border, left heart border, they are all in relation to those intercostal spaces and the lines that I showed you. So most important landmark is the apex. Apex is normal apex is usually in the fifth intercostal space medial to the midclavicular line. So you have to remember the midclavicular where it goes and just beside the nipple, and you have to count the mid intercostal spaces from the sternal angle, that is the second intercostal space, then 2, 3, 4, 5. That way you have to come down. And the aortic area, pulmonary area, and the second intercostal space, remember, they are on the right side is pulmonary area. On the left side, on the right side is aortic area. On the left side is pulmonary area. Then the right tricuspid area is there, just beside the left parasternal area. So M means mitral, that corresponds to the apex. T is the tricuspid, corresponds to the right ventricle. P is the pulmonic area where you auscultate for the second heart sound. A is the aortic area. Now coming to the examination part. So obviously the general examination is the first step when you are examining any patient, and similar is for cardiology. When you start general examination, these are the things you have to remember. I'm sure everybody is aware of it. Pallor, icterus, cyanosis, clubbing, edema. I have only highlighted important parts which are relevant to cardiac system. But other general examination has to be done as per the protocol and taught in your medicine classes. So these are the vitals: pulse, respiratory rate, blood pressure, and that way you have to remember and do a general examination fast. Pallor, why is it important for cardiac patients? Because pallor is a sign of anemia, you all know. And anemia mimics heart disease in almost all the patients. We ourselves have found, we have diagnosed, I mean, heart failure, pulmonary embolism, whatnot. And later on, we found that it was all the symptoms were due to anemia. So recognizing this fact that a patient coming with acute breathlessness, acute chest pain, you should not hurry in diagnosing him as having cardiac disease. This is the first thing that you must, that is highlighted here, that you first step of general examination, you look for pallor, and you may find that all the symptoms are related to anemia. So this is pallor. And second important general examination finding is that you look for is cyanosis. This is cyanosis. Now it's a sign of cardiac disease in most of the cases. We decide how do you define cyanosis? It is blue discoloration of the skin and mucous membrane caused by increased concentration of reduced hemoglobin. When it is more than 5 grams per DL, then visible cyanosis appears, which is the bluish discoloration appears. Now we all know there is two types of cyanosis. One is central cyanosis, which is due to heart or lung diseases. It can be due to intracardiac or extracardiac shunting in heart diseases, congenital heart diseases, or it can be due to lung diseases also, which give rise to central cyanosis. Now, peripheral cyanosis, on the other hand, is usually when we say peripheral cyanosis in terms of circulatory problems, when there is cutaneous vasoconstriction, decreased blood flow, increased oxygen extraction in the skin, and that leads to cyanosis in the nail beds, skin, nose, tip of the nose, ear lobes. So in there, you find this peripheral cyanosis. And this may occur in advanced cardiac patients like heart failure, but usually it's form of a circulatory problems. Then when you're examining, please focus on the skin of the patient. There are many changes of skin that you can see, which give maybe an indicator of underlying cardiac problems or a risk factor for cardiac problem. So the first photograph that you are seeing, earlobe crease, which is a classical sign of atherosclerotic heart disease. This is earlobe crease sign. Sometimes it's called Frank's sign. But when you are examining a patient, elderly patient, or a middle-aged patient with dyslipidemia, cardiac risk factors, and you are examining him, if there is this earlobe sign, you can think that there can be atherosclerosis, and coronary artery disease can be an underlying cause for the patient symptoms. Then other pictures you are seeing, this yellowish discolorations, rashes over eyelids. Then there are tendinous eruptions over dorsum of the hand. There are some eruptions on the skin. These are all different types of xanthomas. So the first is classical xanthoma that may or may not be a sign of dyslipidemia. Please remember, these eye xanthomas may occur without dyslipidemia also, but this one, tendinous xanthoma and eruptive xanthoma. These two pictures are classical for dyslipidemia. The eruptive or tendinous xanthomas occurs in hypercholesterolemia, while the eruptive xanthomas occurs in hypertriglyceridemia. Please remember the difference between two. And tendinous xanthomas, especially if you are seeing a premature atherosclerosis, familial hypercholesteremia, if you are suspecting, you can find big nodules over dorsum of big joints, knee joint, elbow joint. And we have few cases, if I just remember, there was one boy with advanced atherosclerosis, and he had familial hypercholesterolemia, and he had xanthomas all over his dorsum of the joints. So these skin manifestations, you have to remember. The last photograph is petechiae. Petechiae is nothing but capillary bleeds that may or may not be an indicator of direct cardiac disease, but can be an underlying sign of something wrong with the vascular system. Vasculitis can be there. It can be due to antiplatelets that you are giving to the cardiac patients, can be a sign of bleeding disorder. So these are the skin manifestation that you have to look out for while you are examining a cardiac patient. Now coming to the nails. Once you have diagnosed cyanosis, central cyanosis especially, is always accompanied by clubbing. Clubbing is an important general physical sign in cardiology, and it's I'm sure that if most of the postgraduates, if they are listening, they must be knowing how to look out for clubbing, how to grade it, and what is clubbing. So clubbing is painless soft tissue swelling of the terminal phalanges, and they are classically in cardiology found in congenital cyanotic heart disease and infective endocarditis. These two main cardiac problems which give rise to clubbing. And any, I mean, had it been more interactive, I would have gone for those angles. And everybody knows what is the normal angle of the nail fold. It's like 160 degree, and it is called Lovibund angle. And when normally you position the index fingers of a patient, there will be a gap called Shamroth's window. And in clubbing, what happens? This window disappears because that angle becomes wider, and they come in touch with each other. And there is also grading. So the grade 1 of clubbing is obliteration of the angle plus positive fluctuation test, as shown in this photo. Then grade 2 is parrot beak appearance. Once the clubbing advances, the shape of terminal phalanges become parrot beak, then drumstick, and the last stage is hypertrophic osteoarthropathy. And then it becomes painful. It is very advanced. We rarely get to see nowadays, but used to occur in advanced congenital cardiac diseases and lung diseases especially. And other causes of clubbing, there are many theories. I will not go into the details. And this is a mnemonic that most of the undergraduates students remember. All this mnemonic of clubbing causes cyanotic heart disease, L for lung cancer, U ulcerative colitis, bronchiectasis, benign mesothelioma, infective endocarditis, neurogenic tumors, and GI problems like primary biliary cirrhosis, IBDs, and all those stuff. So you can remember this mnemonic also if you wish. Then nail, what are other nail changes that you can detect in a cardiac examination? First photo shows splinter hemorrhages. The splinter hemorrhages are these vertical lines after this white of the nail, and they are classically seen in infective endocarditis. All these signs are seen in infective endocarditis. This one is showing painful nodules at the tip, which is called Osler nodes, and these are the red lesions, which are called Janeway lesions. The etiology and are different. This is immunological phenomena. This is septic emboli. This is also immunological embolic phenomena. So, but all these signs can be seen in infective endocarditis. Now, another general examination finding that you must look for is edema. Edema is a cardinal cardiac problem that is produced due to increase in interstitial fluid. And how do you remember that cardiac edema starts from the feet? So you have to look at the legs, press it, and see the depression. There is a grading of edema also. I'm not sure that you must, you should know at this point, but you must know that edema is a cardinal cardiac sign, and it is most important to see at the legs first. In advanced diseases, it is suppose if a patient is lying down because of advanced failure and is not able to move around, he may not develop edema in his legs. Then you should look for edema in the dependent part of the body. What is that? At the back, he may be having pre-sacral edema. In the back, you can detect edema. And once the heart disease progresses, the edema will involve whole of the body, which is called anasarca. But remember that swelling in heart patients starts from legs and then go up. So when anasarca occurs, you have to take history. Here again, what I highlighted, history is important. Where swelling started, how it progressed. Only one or two conditions where edema is not much, but ascites is more. That is constrictive pericarditis and right-sided heart failures. So you have to remember this exceptional problems. So, and then once we are done with the general examination, now we come to the cardiovascular examination. And the first thing is arterial pulse. As I said, vascular examination starts with vessels. So what do you look for arterial pulse? Rate, rhythm, volume, character, condition of the vessel wall, equality on both sides, radiofemoral delay, other peripheral pulse. So you have to remember all the sequence. What students miss is they sometimes either they do a shortcut, they don't put all the points, and that may be problem in the exam. And you don't have to say like rate is this, rhythm is this. You have to make a flow that patient is had. Suppose what you want to tell, like 80 beats per minute, regular rhythm, normal volume, the character is normal. Or if you are finding any special character, then you have to the condition of the vessel wall is normal or abnormal, stiff. Both sides pulses are felt. There is no radial or radiofemoral delay. That's how you have to write about the pulse. So but the sequence has to be like this. You have to remember all the points, and all the points should be mentioned in your pulse record. And these are I will come to it. And once you have measured everything, then there are some things like if your rate is slow, it is called bradycardia, which can be physiologically seen in athletes, children asleep, but pathological can be because of severe hypoxia, hypothermia, myxedema, acute infravolemi. Raised intracranial pressure is also give rise to bradycardia. And drugs, obviously, all the rate slowing drugs can produce bradycardia. Similarly, for tachycardia, it can be normal in children, emotions, post-exercise. Pathological tachyarrhythmias can occur in high output states like thyrotoxicosis, beriberi, heart failure, acute MI, especially anterior wall MI, and some drugs like atropine, thyroxine, etc. Then once you have calculated the rate, then comes to rhythm. Obviously, the normal rhythm is regular, but some younger patients, children, can have some variation with respiration that is called sinus arrhythmia. Sinus arrhythmia may have different beats, different rhythm during inspiration and expiration, and that is called a sinus arrhythmia. But a regularly irregular rhythm, if it is occurring, it is a sign of atrial arrhythmias with fixed AV block, ventricular bigymny or trigymny. And irregularly irregular rhythm, you have to remember only one cause, that is atrial fibrillation. Then coming to volume, which is very important for you to understand, you have to assess the volume by palpating carotid arteries because they are closest to heart and best to assess the volume. And pulse pressure gives accurate measurement of pulse volume also once you have measured the blood pressure. The normal pulse pressure is 30 to 60. When you are getting a pulse pressure of 30-60, you have to mention that is a normal volume pulse. When the pulse pressure is narrow, that is less than 30, what is pulse pressure? I hope you all know that it is a difference between systolic and diastolic blood pressure. When the pulse pressure is low, it is called a narrow volume pulse, small volume pulse. And when the pulse pressure is more than 60, it is called hypervolumic pulse or a large volume pulse. Pulse volume depends upon stroke volume and arterial compliance. So, sorry. Now coming to the different characters of the pulse, because in pulse, pulse gives information about various cardiac diseases. So normal pulse obviously is a dicrotic notch. There is a percussion wave P. You can see the top of there is a sharp rise, then a gradual decline. Then there will be a dicrotic notch in a normal pulse, and then goes into again next bit will rise, goes in down dicrotic pulse. So this is a normal volume pulse. The pulse pressure will be something around 30 to 60 millimeter of mercury. Remember the link between pulse pressure and the volume of the pulse. Then the hypokinetic pulse, where there is volume is low, you will find this pulse in various obstructive valve diseases, AS, MS, low ejection fraction patients, DCMP, dilated cardiomyopathy. So as you can see, the top is truncated. So the systolic blood pressure has gone down. Dicrotic notch is not that impressive, and there is a gradual decline. So this is a small volume pulse. An extreme form of a small volume pulse is the anacrotic pulse, where the dicrotic notch is absolutely not visible. There is especially rise of the pulse is very slow. So it is also called parvus et tardus, slow rising pulse. And it is a classical finding of severe valvular AS, where because the cardiac volume is fixed and because of the obstruction, so ejection is prolonged and the ascending limb of pulse is very slow to reach the peak. So this is called slow rising and late peak, parvus et tardus. Remember, this is found in severe valvular AS. Then there is hyperkinetic pulse, which is opposite of the delayed pulse. It is reaching the peak early. There is a sharp ascending limb, reaching the peak early. There is a dicrotic notch and then goes down, which is found in high output state, mitral regurgitation, ventricular septal defect, because there is rapid ejection, give rise to large volume and wide pulse pressure pulse. A severe form of hyperkinetic pulse is called collapsing pulse, which is found in severe aortic regurgitation, PDA, RSOV. This collapsing pulse should not be confused with, hyperkinetic pulse. Collapsing pulse is an extreme form of hyperkinetic pulse. So in anemia, you can get hyperkinetic pulse. In MR, you can get hyperkinetic pulse. But when you say it is a collapsing pulse, it is a sign of reduced peripheral vascular resistance. But means something is going away from the peripheral blood vessels. So it will be only seen where there is a shunting between large vessels or left side of the heart and a pulmonary artery. So it's seen in severe AR, PDA, remember, RSOV and AV fistulas, collapsing pulse. And it is also called a water hammer pulse because of the toy that you see, the water hammer, it goes down, picks up again, goes down, picks up again. So that's how it has been called a water hammer pulse or a Corrigan's pulse. These are other names for the same thing, collapsing pulse. And here the diastolic pressure, because there is a peripheral runoff, diastolic pressure can go up to 0. that you must remember. Another pulse is pulsus bisferiens, double peaking pulse. So what you will see here is a form of, again, a hyperkinetic pulse, but there will be two peaks during systole. Two peak during systole. Rapid rise, one peak, then another peak, then goes down. A small dichrotic pulse, then goes down. And this, again, bisferiens pulse can be seen in severe AR, but classically it has been taught that bisferiens pulse is seen in AS with AR and HOCM. These two things causes pulsus bisferiens. A word to remember is HOCM. Hypertrophic cardiomyopathy has very similarities with severe valvular AS, but some differentiating points are in the pathophysiology of HOCM and AS, and one of them give rise to this pulse. So HOCM will give pulsus bisferiens, while severe AS will lead rise to pulsus parvus et tardus. So please remember this. If you are saying slow rising pulse, never say HOCM. And another low volume pulse is dichrotic pulse. This is found in very sick patients where there are two peaks again, but it's different from the bisferiens. Here, the second peak is in diastole. So very low volume pulse, two peaks, one in systole, one in diastole. Pulse volume will be very narrow. Maybe patient will be in shock, and they are seen in extremely sick patients: cardiogenic shock, dilated cardiomyopathy, tamponades, dehydration, sometimes with low blood pressure, left ventricular failure. The sign of sick patient pulse found in pulsus alternans. When one beat will be a high volume, another beat will be a lower in volume. One beat high volume, another beat low volume. The pathophysiology being once the heart, because heart is weak because of underlying heart disease, severe LV dysfunction. So the beat which gives high volume, then heart becomes more less efficient in the next beat, and so it gives rise to a smaller beat in the next. Then it recovers a bit, gives a big pulse, again goes down. So this is called pulsus alternans. Again, this is best appreciated by palpating peripheral arteries. Remember this, pulsus alternans is felt in peripheral arteries like radial and femoral arteries. It should not be confused with pulsus paradoxus. So one is pulsus alternans, which is seen in sinus rhythm patients with severe LV dysfunction, sick patients, cardiogenic shock. While pulsus paradoxus is again seen in sinus rhythm, but here what happens, this variation of the pulse is linked to respiratory cycle. So once the inspiration increases RV volume, pushes the septum, LV compliance is less, and this increase in the increase in the RV volume during inspiration does not translate into increased LV ejection. In fact, LV ejection is decreased. So in inspiration, the BP will fall down. In expiration, it will increase. It is a normal thing, but is it exaggerated during some of the pathological conditions? Classically, cardiac tamponade. Remember this. So this is the pulsus paradoxus. And why exaggerated? The value is 10 mm. In a pulse difference of 10 mm Hg till 10 mm Hg is acceptable as a normal variation between inspiration and expiration. But if this difference is more than 10 millimeter of mercury, then it is a pathological finding, and it is classically seen in cardiac tamponade. Some of the effusive constrictive pericarditis patients, airway obstructions, and SVC obstruction. So very important finding to remember, pulsus paradoxus. And again, it is also very it is seen in peripheral arteries. You appreciate it mostly in femoral arteries. Femoral arteries best to assess pulsus paradoxus in my view. And in some extreme cases in tamponade, we have seen that pulse absolutely disappears during inspiration. Absolutely disappears during inspiration and comes back in expiration. So you put a palpate femoral artery, patient is inspiring, pulse is going, there is no pulse. In expiration, pulse comes back. This is an extreme sign of pulsus paradoxus. Half ho jata hai. Then another, when you are palpating pulse, you may find there is deficit between apex heart rate and a pulse rate. Classically seen in pathological conditions like atrial fibrillation, arrhythmias. But atrial fibrillation is a classical example. When the rapid rate is there, some of the short interval heartbeats they do not generate so much of cardiac output that they go into the peripheral pulse. So there will be a difference in the heart rate when you auscultate at the apex, while the pulse rate when you are palpating will be less. So this is called apex pulse deficit. If it is more than 10 to 15 millimeter of 10 to 15 per beat per minute, then it's sign of underlying atrial fibrillation. Then obviously you have to assess the peripheral pulses. Very important, all the pulses should be examined. And if there is delay between radial and femoral artery simultaneously, it's sign of obstruction in the aorta. It can be a coarctation of aorta, it can be aortoarteritis and other constrictions in the aorta. So this is a very important sign that you must remember while examining a cardiac patient. You can also palpate the dorsalis pedis peripheral arteries. So dorsalis pedis, if it is absent, it's a sign of peripheral vascular disease, again, coarctation and aortoarteritis. Once you're done with the pulse, then come to the blood pressure, which is measured by an sphygmomanometer. I am sure you must be knowing how to measure blood pressure, and there are various methods are there. You know, Kortokov sounds. What I want to highlight is what are the best practices to measure blood pressure. So these things you must be knowing. So the best practices are, the first thing, the cuff size should be appropriate. What I mean by appropriate, it is defined as the length of the bladder should be twice that of the width. Average length of the bladder should be 25 centimeters. And it should extend for at least 2/3 of the arm length and circumference. Please remember all these points. They are because everybody's arm is different, children are different, adults, even in adults, there is one obese patient. So you have to have an appropriate blood pressure. Then only you can say, otherwise there is spurious reading, which is called pseudo hypertension, either a false low blood pressure you will record, or a false high blood pressure. So these are the sizes. You can go in your textbooks. These are the appropriate sizes of the bladder, which you measure. And it is available whenever you are in a ward or a clinic. You should have different sizes of bladder to measure blood pressure in appropriately. Preparation of the patient is most important, which we forget in our daily practice. And it is also one of the reasons for false blood pressure reading. So what are the preparation? Patient should have rested for 15 minutes before measuring blood pressure in a quiet room, should not have consumed coffee, tea for at least 1 hour, should not have smoked in last 30 minutes. 15 minutes is very short, I will say 30 minutes. Should not be on adrenergic stimulants, various drugs or anything. And in elderly patient, please remember the elderly gentleman should have emptied his bladder. That is one of the cause for spurious high blood pressure reading in your office. Patient comes from heat outside, sits in your AC chamber, is maybe his bladder is full. You call him, you measure his blood pressure may be 180. You ask him to relieve himself, comes back, you measure blood pressure, might be 130, 140. So these are the things that you must remember before measuring blood pressure. So these are, I'm giving this facts from recent AHA guidelines. So most of the things I have mentioned you. And while you, how will you, what are the position, how will you measure blood pressure? Patient should be sitting in chair with their feet flat on the floor, back supported. Patient should be seated for 5 minutes without talking or moving around before recording the first BP reading. Okay. So, and you can measure blood pressure either with the diaphragm or the bell. And one word about, when I talked about elderly person, very important that elderly person should have an orthostatic BP check also. Once in a sitting position, and then you make the patient stand and take blood pressure after 2 minutes or 3 minutes from the lying position. And if the difference is more than 20 million of mercury, then the patient has orthostatic hypotension, and the causes can be drugs, hypovolemia, dehydration, autonomic neuropathy, and other things in diabetic patients. So these are the best practices. And one thing more, when you are measuring up blood pressure for the first time in a patient, please remember to measure in both his upper limbs, and in children, in young patient less than 20 years, also in leg. Why? Please go to the previous slide and remember that patient may be having peripheral vascular disease, congenital heart disease like coarctation of aorta, which aortoarteritis, which may give rise to difference between blood pressure. And it is more important also in an acute emergency case. Patient coming with chest pain, please remember to measure blood pressure in both his limbs. Because if there is difference of more than 20 milliliter of mercury in a patient of chest pain, please think of aortic dissection also, apart from myocardial infarction. So this is my extra bit of blood pressure. And most of the other things are, very theoretical. I'm not sure whether time permits. Ajay sir, is there time or any time
No,
limitation?
we have still a lot of time. Go ahead.
Okay. Thank you.
Go ahead and sort. No problems. Thank you.
Okay. Then another examination is we are done with the artery. Now come to the vein. Why I am highlighting on these parts? Because again, please, when we are examining heart, don't get lose focus on heart only. Half of your diagnosis will be done by examining arteries and veins. Even more than that, a seasoned clinician like Ajay sir will agree that once you examine arteries and veins, most of the diagnosis will be clear. So another important thing is jugular venous pulse. It is important for exam also. So please remember that you pass or fail on JVP. So what is jugular venous pulse? It is fluctuation in right atrial pressure during cardiac cycle generates a pulse that is transmitted backwards. And because internal jugular vein is direct contact with the right atrium, you see the fluctuation with your eyes. It is, again, what is the best position? Traditionally taught in 45 degrees, but you can, if jugular venous pulse is visible in sitting position, you can assume that jugular venous pulse is raised, and you can mention it, and you can identify all the waves. So it is not sacrosanct that you have to examine in 45-degree position, but it is a standard practice to examine in 45-degree reclining position. So at 45-degree, venous pressure just appears at the border of the clavicle, sternoclavicular joint. But normally, jugular venous pulse in a normal person with a normal heart, normally it's not visible. And then you measure it with the sternal angle, and that is reported in centimeter of water. What is the top of the jugular level? That is the jugular venous pressure. What you see is the jugular venous pulsation. When you measure it, that is called jugular venous pressure. Okay, so see the diagram. So once it is in a straight line, the right atrium is connected to the internal jugular vein. You may not see it. Once you elevate a bit, then the pressure pulsations will appear here. And when you measure the top of the pulsation, that is the jugular venous pressure, from where you will measure from the from the sternal angle. This is the sternal angle, that is mid of the right atrium, and from there, the top of the jugular venous pulse is measured, and that is reported in centimeter of water. So JVP in health should be less than 4 centimeter. So normally it's not visible, but once it's more than 5 centimeter above, and you add 5 centimeter of that right atrium, it becomes 10. Then it is elevated. This is a video that I got for you, how you should, this is a traditional teaching. Either you put a light tangentially on the top of the wave, or you can do this. You can see in the slow motion and how beautifully they have described various waves of the jugular venous pulse. So this is how you should be measuring jugular venous pulsation. I will come to the individual waves in the next, but that video I found to be useful, and you can see it in the slow motion also. You can see the pulsations. How to identify various pulsations? Always look for the descents. Don't look for the bulges. Once you look for the descents, it will be more apparent. So the down going waves are more prominent. Remember this. So these are the various waves of jugular venous pulse. Start with A. A is atrial systole when the atrial contracts. C is the closure of tricuspid valves. Generally, C wave is not visible with the eye, so you should not mention C wave. Most visible is the descent, X descent. First is the X descent, which occurs during systole when atria is relaxing and valves are going down in the systole. And once the waves open, then there is a V wave. This is a second positive wave after the first descent. And then there is a rapid descent. The second descent is VY descent. It is commencement of the ventricular filling when from the right atrium, blood is going into the right ventricle. So this is different waves. I hope you remember, but important point to remember is that descents are more visible. So the A to X descent in systole, you can time it with the first heart sound. That in systole, this descent is the X descent, and during filling, it is the Y descent in the diastole. And then there is a gradual rise, then again atrial contraction, then C descent. So there are various pathological conditions in which different waves become prominent. Normal JVP, as I explained. Giant A waves means there is atrial compliance issue and there is atrial contraction is producing giant A waves that can be seen in tricuspid stenosis and pulmonary stenosis, tricuspid stenosis. Canon A waves are seen in complete heart block when heart contracts against a closed AV valve. Giant V wave is seen in TR, AF, and prominence descents are seen in constrictive pericarditis. I think there's some slides not there for JVP, but JVP is important part of examination. Now coming to the examination of the precordium. So first is inspection. Inspection for chest wall abnormalities, position of trachea, apex beat, other pulsations, dilated and engorged veins, surgical or any scars of cardiac surgery. So you do inspection. In cardiology, generally inspection and palpation are done together. But for information, I'm just separating it. So precordial bulgings, first thing you notice is the shape of the precordium. If this is first photo is showing pectus carinatum or pigeon chest, then pectus excavatum. This is pigeon chest, pectus carinatum, kyphosis, scoliosis, and all these are related with underlying heart diseases, congenital heart diseases. There are many valvular diseases, especially of the right side, pulmonary stenosis, peripheral pulmonary artery stenosis, which are associated with chest deformities. And many congenital heart syndromes associated with TOF is also associated with chest deformities. So chest deformity is important to inspect on inspection. Then apex bit, we discussed that it is a normal location is in the fifth intercostal space, just medial to the mid-clavicular line. And what is the normal pulsation? It just taps and goes. Then in disease, the apex becomes abnormal. Apex, sorry. Yes. So normally in the fifth intercostal space, half-inch medial to the mid-clavicular line, an enlargement of the heart, either due to hypertrophy or dilatation, may shift the apex. So if it goes down and out, it is usually sign of volume of pressure over the left ventricle. Sometimes there is heaving. It is in pressure overload situations, hyperdynamic in volume overload conditions. So pressure overload will produce heaving apex, which is seen in aortic stenosis, hypertrophic cardiomyopathy, while the hyperdynamic apex, which is very rapid touch and rapid go, and it is out and down, that will be seen in volume overload, like mitral regurgitation, aortic regurgitation, and ventricular septal defects. And character of the apex is a normal will just briefly lift your finger or it will just touch and go. Diffused is hyperkinetic, and tapping apex is seen in mitral stenosis. Heaving and hyperdynamic I already explained. But many a times it may not be palpable, either due to obesity, COPD, pleural effusion, pericardial effusion. So you can ask the patient to lean forward in left lateral position or lean forward, and then you can palpate the apex beat. What is parasternal heave? Parasternal heave, once you have examined apex, you have to come to the right parasternal area, so left parasternal area, and examine with your dorsum of the palm. You put there, and if it is just touching and going, it may be, especially in a thin build patient, it may be normal RV pulsation. But if it is sustained, heave, then it is a sign of pressure or volume overload of the right ventricle. Till now, we were discussing apex of the left-sided apex. Now it is a sign of right-sided diseases. So the volume overload of right ventricle occurs in pulmonary stenosis, pulmonary arterial hypertension. The volume overload of right ventricle occurs in tricuspid regurgitation, pulmonary regurgitation, all those things. But it will produce a sustained rise of the left parasternal area in the fourth and third parasternal space. Along with palpation, you can palpate thrills. Thrills are also sign of underlying heart disease because it sign of palpable murmur, as you said, valvular diseases, which you can feel with the thrill. So thrill is a palpable murmur. It is produced when blood passes through a narrowed valve or when there is abnormal blood flow, as in congenital defects, or if the blood flow is rapid. And it is also can be seen in direction of the flow in the veins, SVC obstruction or IVC obstruction. Now, percussion. Percussion has a limited role in cardiac examination. It's not as useful as in respiratory diseases, but still you have to have a knowledge of cardiac percussion. Why do we percuss in cardiac patients? Is to know the border of the hearts. So first thing is to know the border of the heart. As I said, in the surface markings, you must remember left side of the border, right side of the border, and then you can make whether the heart is enlarged or normal in size. So you have to, the principles is same as you normally percuss in other respiratory diseases, but just have to note the dullness, the resonance, and the tympanic. Cardiac pulmonary diseases also can be picked up by percussion. If the border of the heart is dull to percussion, only thing you can diagnose is pericardial effusion. Again, I'm highlighting percussion is not very diagnostic in cardiac diseases. So this is the border of the heart here that you can percuss, and right border of the heart you can delineate, left border of the heart you can delineate. Ajay sir, I think auscultation will be too much for today. So
quickly, 1 or 2 minutes, you can just give a quick revision of auscultation.
auscultation, okay, I'll just try to finish it.
Yeah.
So
Yeah.
because auscultation is important, it may take a longer time. But
Yeah.
for students to conclude this talk, auscultation is the last part of cardiac examination. And there are 4 areas of cardiac anatomy that you have to auscultate: a mitral area, tricuspid area, pulmonary area, and an aortic area. So the mitral and tricuspid corresponds to the left ventricle and right ventricle. So generally the sounds that you auscultate there is related to the first heart sound. There are 2 components of first heart sound. The mitral closure that you hear is M1 and tricuspid that you hear is T1, but they are not, you cannot really differentiate between the 2 components of the first heart sound. So the first heart sound is reported as such, as a first heart sound at the apex, which can be normal, loud, diminished, or muffled. The second heart sound corresponds to the aortic pulmonary valve closure following ventricular ejection. And they are, because the timing is different, the timing of closure of the valves is different. So you can appreciate the closure sound of pulmonary valve separate from the aortic area, and respiration enhances this differentiation, which is called splitting of the second heart sound. So how do you auscultate? You identify, as I said, first heart sound at the apex and the tricuspid area, second heart sound in the aortic and pulmonary area. Assess their character and intensity. Note, please remember that splitting is very important to report when you are describing second heart sound. Without splitting, you will not pass the exam without mentioning about splitting. And palpate from the carotid pulse. S1 barely precedes the upset. You can, like, timing with the carotid pulse, you can evaluate first heart sound, and second heart sound will be away from the carotid pulse. So you know that the second heart sound, lub dub, that you are hearing, one is away from the carotid, one is with the carotid. So the thing which is coinciding with the carotid is the first heart sound, which is away from the carotid is second heart. This is the starting practice that you can do to identify the first and the second heart sound. So the first heart sound, the lub, is caused by closure of the mitral tricuspid valve, onset of ventricular systole. Normally, splitting is not heard. And these are the three, the loud first heart sound you listen classically in mitral stenosis. You can listen it in tachycardia, sinus tachycardia. But the muffled heart sound will be seen in low cardiac output, mitral regurgitation, and other heart blocks. And AF, VPCs, arrhythmias will obviously give to the variable intensity of first heart sound. When you are describing first heart sound, you have to describe about the sound, then the intensity, and then you move ahead to the second heart sound. Now, it is caused by the closure. As I said, there is difference is perceptible of the two components of the second heart sound. That is, should be reported as such, A2 and P2. P2 is the pulmonary component of second heart sound. A2 is the aortic component of second heart sound. And this is the splitting that I was talking about. The splitting is normal respiratory variation, basically, that I have been telling you all along, that in inspiration, RV volume increases. In a normal heart, that results in increased cardiac output during inspiration. So the increased filling closes the pulmonic valve first because the pressure deficit closes first, and then P2 is delayed and A2 comes first in respiration and becomes narrower in expiration. So the splitting increases at end inspiration because increased venous filling, and separation disappears on expiration. That is basically the splitting of the second heart sound. And you have to say a normal splitting. When it becomes pathological, I think the classical example is ASD. So when you say a wide splitting of second heart sound, you have to mention whether it is fixed or whether it is variable. So the fixed splitting of second heart sound occurs in ASD, atrial septal defect. It is a classical of ASD, but can occur in bundle branch blocks, severe pulmonary hypertension. But then it is not fixed. So any condition which is increasing pressure on the RV side will enhance the splitting of second heart sound. P2 will be more and more delayed because RV is taking time to eject. The fixed splitting always occurs in atrial septal defect or an advanced right heart failure. Variable splitting occurs in right bundle branch block and pulmonary hypertension. There is another thing is reverse splitting, which occurs in LV outflow obstruction like HOCM or left bundle branch block. So this is about second heart sound. Additional sound that on auscultation you have to remember is third and fourth heart sounds. It is again signs of cardiac pathology. Third heart sound physiologically can be seen in pregnancy, fever, athletes, but usually it is a pathological finding of a dilated heart. When will the heart dilate? Heart dilates in mitral regurgitation, dilated cardiomyopathy, left ventricular failure. So there they will produce third heart sound. That is the additional heart sound. And when it is associated with tachycardia, especially in heart failure, it is called a gallop rhythm. Other added sounds which are important for cardiac pathologies are opening snap in mitral stenosis, ejection clicks in valvular aortic stenosis or valvular pulmonary stenosis, mid-systolic clicks of mitral valve prolapse, pericardial rubs, pleuropericardial rubs. And then you decide about murmurs. Once you are done with the heart sounds, then you try to find out about murmurs. Murmurs again are described in timing, duration, character, intensity, location, and radiation. All the points are important in describing murmurs. So, sorry. So some. So I'll conclude how it's reported as right.
Yeah.
And just a second. Just a second. So this is how you should report in a cardiac patient once visible, right? But
Yeah,
not
yeah,
full
yeah.
screen, but not full screen. Yeah.
No problem. Just go ahead,
Yeah.
Nishant.
I'll just conclude,
Yeah,
sir.
yeah. Summarize. It's good. It's good, Nishant.
I think uh, so. You have to do like in all the cases, you have to give a general physical examination, the signs that I told if you are getting any neck vein examination, pulse, BP. Then inspection, you tell about whatever findings is there. If there are normal findings, you have to write all those things that it is normal, apical impulse seen in everything has to be described as per point wise. Palpation, I told you, you have to percussion, you can mention, but percussion is well not very important. Auscultation, you have to write everything, especially second heart sound. Don't forget to mention about splitting, additional sounds. If you're not getting any additional sounds, write no additional sounds. If you are getting additional sound, mention about it, whether it is opening snap of mitral stenosis, click of an aortic stenosis. If you're not getting anything, write no additional sounds, but you have to mention it. There is no S3, no S4, no additional sounds. So this is how you report. If you are, I think, pathological findings, it will take time. And I guess, sir, I hope I've done justice to
Yeah,
it. It's
absolutely.
such
You have done great thing. Yeah.
a vast
Uh,
subject that
Nishant,
everything will not be
nobody
taken.
is teaching us in such a detailed things now, nor we
Sir,
teach our students.
sir,
That's
sir.
a the era of clinical medicine is almost gone.
Yes, yes,
So everybody, orders for a X-ray, starts with X-ray or
yes,
echo
yes.
or things like that.
Sir,
So
sir.
we start our cardiology practice with echo. That's a
Right,
bad thing because
right,
we are forgetting our past, how the
right.
clinical teaching has contributed
Yes,
a great way.
absolutely. Absolutely.
And
We would, sir, at this point, I would like to mention two things. Sir,
yes, yes,
sorry
yes.
to interrupt.
But
I'll just put two things. If younger colleagues are listening to me
yeah, yeah,
or the
everybody is
students,
listening
if,
to you.
yeah, yeah.
I am
As
also
sir was,
listening very carefully.
as sir was mentioning, sir has even seen a harsher era of clinical medicine.
Yeah,
I know him because uh, we would have been like kicked off out of our wards or whatever if we don't follow the pattern of clinical examination. I mean, I cannot do echo without auscultating the patient.
correct.
So this
That
is
is
the
what.
first step. Please remember, echo will not give you diagnosis if you have not examined the patient. And sorry to say, uh, I am getting reports on, which gives a suggestion that there's something training is lacking there.
Definitely, absolutely.
And if you don't examine, you will miss things. It doesn't matter if you have done an echo, if you have done a CT, you have done an X-ray, but you will miss things if you have not done meticulous examination. I've seen people missing coarctation of aorta, valvular
Yeah.
AS, even after doing echo. Uh, so it's just for younger colleagues to stress upon the fact that clinical examination will never go, no matter how much technological advance we become.
Yeah, yeah, yeah,
Final
yeah.
points from you, sir.
I think it has been a great learning for me also. It was a total revision for me.
Yes.
And only message I want to give uh, to our young friends, they call you after 1 minute. Uh, Young friends is, I even now, when I in Medanta OPD, when I start examining a patient, I examine from the lower limb.
Yes,
I
absolutely.
touch the feet. So people ask me, why do you do that? I said, this is my practice from PGI days. That's
Yes,
what I'm doing today also. So complete examination, clinical examination will give you a diagnosis. As Nishant was telling that most of the time when you take the proper history taking is a very, very important part of clinical examination. If you take a history, not only patient, but attendance also. And like talking to the patient itself will give you half the diagnosis. And another half will be obtained after examining, being a
correct.
general examination. So
Correct.
thank you very much, Nishant.
Thank you,
Any
sir.
question
Thank you.
anybody has got? Any of our friend has got any question? Please let us know. Any questions from our colleague, our young students? Any question? Anand, any question from anybody?
No, sir, there is no question in chat box, sir.
Okay. So thank you
Okay.
all.
Thank
Thank
you.
you all
Thank you,
very much.
everyone. Thank you, everyone.
And Nishant,
Sir, nice to see you.
thanking you
Sun is,
from core of my heart, because despite your busy schedule and you've been
no,
traveling
sir.
and you're away from Patna, you are able to give us your time. Thank you very
Right.
much.
Thank you, sir.
And
Thanks.
thank
Sun
you
is,
API. And finally, thank you uh, the dot 3 dot life
three
sciences,
dot.
who
Yeah, yeah.
has who has been helping us right from the beginning.
Sir,
So
sir.
thank you all very much. Nishant, bye bye.
Sun is shining bright. Enjoy your day.
Yeah, yeah,
Yeah.
yeah.
Thank you.
Yeah.
Thank you, sir. Good night. Oh, good
Bye bye.
morning. Bye. Bye.